Hi, my name's Dr. Brad Denker. I'm a nephrologist at the Beth Israel Deaconess Medical Center, and it's my pleasure today to share with you Electrolyte challenging questions and answers. This is divided into two parts, and it's 25 questions, although the time will be approximately split between the two presentations. As you can see, this first part are more involved questions and will be questions 1 through 9. The format will be a case followed by some choices, a pause to allow you to think about the correct answer, and then a review of the background for why one answer is correct and the others may be incorrect. I have no financial disclosures to report for this presentation. So, case number 1. This is a 35-year-old male with bipolar disorder treated with lithium and is referred to your clinic for chronic polyuria and polydipsia. He complains to you that he has to void about once every hour. Some basic laboratory results return, and it's found that his serum sodium is 146, BU and creatinine of 35 and 1.9, a serum osmolality of 305 milliosmoles per kilo, 5 liters of urine output in that 24-hour collection, with a urine sodium of 28 milliequivalents per liter and a urine osmolality of 190. This is a very common presentation in general practice as well as in nephrology. And the point of the question is to focus on the sodium disorders that we talked about in the basic discussion previously. So the question that you might see is, which of the following might be appropriate in the management of this patient? Would you try to stop his lithium if possible? Would you treat him with demeclocycline, a V2 receptor antagonist such as tolvaptan? Would you recommend fluid restriction or furosemide, a loop diuretic? I'll give you a moment to think about the choices, then I'll provide the correct choice and then some discussion. Okay, so hopefully most folks recognize that this is lithium-induced diabetes insipidus. And now let's go through the facts of the case that lead to this diagnosis. And it turns out that this is the correct answer, and that all of these, as I'll show you, and we'll come back to this at the end of the case, would actually be harmful for someone with hypernatremia, but are acceptable treatments for the treatment of hyponatremia, of which we'll discuss later. So when confronted with a patient with hypernatremia, and this should be a review based on the background discussion we had earlier, you want to start by looking at the urine osmolality in milliosmoles per kilo. And basically, you can divide them into 3 broad ranges: a low urine osmolality, intermediate, or high. So this is the milliosmoles per kilo, which is essentially the osmotic concentration in the urine. And if you wanted to know the total osmotic excretion, you would multiply this by the total volume of urine that the patient provided. And in this case, it was 5 liters, and the urine osmolality, you will recall, was 150. So it was about 750 milliosmoles per day. But you don't need the 24-hour collection. You can do this on a random urine and just by knowing the concentration. And a patient with hypernatremia can certainly get there by being dehydrated. We've all seen this. Hot summer days like maybe we're having now due to insensible fluid losses or water loss will lead to a concentrated urine and a high urine osmolality. Typically, people will drink because they become hypernatremic and get thirsty. But if they don't drink, then they can become hypernatremic. The other unusual form of this would be if someone were to overdose on salt. So this might be someone who drank seawater for reasons, of being shipwrecked or something exotic to that effect. Or very rarely, people will actually try to commit suicide by taking vast amounts of sodium. And as I showed you in the intro lecture, a high sodium concentration can be achieved by a lot of salt and a little bit of water, or more typically, less water in the same amount of salt. The other way that one can become hypernatremic is by renal water losses. And this can happen through two general mechanisms. One would be through an osmotic diuresis, so some non-reabsorbable component ends up in the urine, and because the kidneys can't reabsorb it, it drags salt and water with it, but more water than salt, so you become hypernatremic. The classic example of this would be uncontrolled diabetes and hyperglycemia with a lot of glucose in the urine. This would be considered an osmotic diuresis. But pure renal water losses with a dilute urine, as we saw in this gentleman, are seen in patients with diabetes insipidus. And diabetes insipidus is either the absence of antidiuretic hormone, as you might see in CNS tumors or after CNS surgery, or nephrogenic diabetes insipidus, where ADH is around, but the renal tubules, the collecting duct, are resistant to its action, so that you end up essentially with an ADH deficient state and unregulated free water excretion. So this gentleman falls in this arm of the algorithm. His urine osmolality was 150. He's on lithium, as I'll show you in a moment, which is a common cause of diabetes insipidus. And management can be difficult, but as the question alluded to, stopping the lithium would be one approach, although in my experience, many patients won't let us stop the lithium because it's such an effective drug for their manic depressive illness. So a few more words about nephrogenic diabetes insipidus. You can see here under tubule interstitial conditions, lithium, although at the bottom of the list, is actually the most common that you'll see in the outpatient setting. There's a variety of conditions you might see in the hospitalized patient, such as someone who had relief of an obstructive condition, recovery from ATN, less commonly myeloma or sickle cell disease. And then there are two electrolyte disorders to keep in mind, particularly for the boards when they are present in a chronic condition, can also lead to diabetes insipidus, and that would be chronic hypokalemia or chronic hypercalcemia. And chronic renal failure is listed, but it's an unusual manifestation of chronic renal failure. Clinically, it's often helpful to distinguish whether this is central diabetes insipidus versus nephrogenic. And the way you would do that would be to deprive the patient of water and then administer DDAVP or vasopressin, and then see the renal response to the exogenously administered DDAVP. If you're missing it due to a central nervous system lesion or problem, the collecting duct will appropriately respond and concentrate the urine, and you can make the diagnosis of central DI. Whereas in nephrogenic DI, the problem is more resistance to the circulating ADH. So giving exogenously administered higher doses doesn't usually have much of an effect on the urine osmolality, and you would make the diagnosis of nephrogenic DI. These are done sort of more in the real world in a practical way as opposed to a formal water deprivation test, but it's a useful way to think about the physiology and the underlying mechanism. A brief word about how you manage hypernatremia. This would typically be in the hospitalized patient. You want to replace that water deficit, because remember, hypernatremia is predominantly a deficit of water, and that the treatment is going to be to replace that water. You want to replace it relatively slowly, about half the deficit in the first 24 hours, and ideally no more than about a half a milliequivalent per hour of sodium correction. For those of you that like formulas or want to remember formulas or look them up, this is the formula for estimating the water deficit in someone with hypernatremia. It turns out that there were some recent studies suggesting that the concern about rapid correction of hypernatremia is much less so than what we think about with hyponatremia, where we worry about central pontine myelinosis and cerebral edema that we'll see coming up on some subsequent cases, and that the treatment of hypernatremia probably can be a bit more aggressive. You want to look at the clinical condition and replace the ongoing free water losses. And if you can, try to treat the underlying cause. You can give back vasopressin if it's a deficiency due to central DI. But unfortunately, we just have sort of indirect treatments for those folks with nephrogenic DI. And these are attempts to reduce the urine volume by reducing the solute excretion, or there is some evidence that giving diuretics may actually reduce the urine output. That may seem counterintuitive, but what happens is you induce a little bit of volume depletion, and that stimulates proximal sodium and water absorption, so that then there's less water delivery to the collecting duct, and you may have a modest effect on reducing that annoying polyuria that our patient complained of. So back to the choices. Discontinuing lithium was the correct answer, and I suspect most of you selected that. The reason these other choices are incorrect are now shown. So demeclocycline actually is used for the treatment of hyponatremia, as I mentioned at the beginning of the case. It's an old treatment that indirectly interferes with the action of ADH and promotes more water excretion. So anything that promotes more water excretion is going to exacerbate or worsen this person's hypernatremia. We have better drugs now than demeclocycline. We have direct vasopressin receptor antagonists. Again, you would not use that in this situation. It can be used, although the indications are pretty slim, for use in symptomatic hyponatremia, particularly the syndrome of inappropriate ADH. You wouldn't fluid restrict. You want these people to drink as they get thirsty. That'll correct their sodium. And of course, furosemide would block the ability to concentrate the urine, result in a dilute urine output and increased water excretion, so isn't going to help here either. All right, let's move on to case 2. As I mentioned, this first series of cases are all focused on electrolyte disorders and are more involved than some of the subsequent cases. So in this elderly woman who's found after 2 days of being unresponsive after a fall and has hypernatremia and a high urine osmolality, a variety of things could be going on. So which of the following statements is most accurate? She has intracellular volume depletion, but actually normal extracellular volume. Should we give her 3% saline initially in order to minimize the gradient of her serum and administered fluid gradient? Should we lower her to 140 in the next 24 hours? Or is it one of these two, that overly rapid correction of her hyponatremia could cause osmotic demyelination syndrome? Or if we correct her too quickly, would we potentially cause cerebral edema? I'll give you a moment to think about those. Then we'll identify the correct answer and discuss why. This is a little bit of a tricky question and one that will be worth talking through. So the correct answer is that rapid correction of her hyponatremia could cause cerebral edema. So let's take a look and see how that occurs and why these other choices weren't the best. So you've seen this before. This is our hypernatremia and urine osmolality. This woman has a high urine sodium and osmolality. Sorry, she has a high osmolality. We were not given her urine sodium. One would actually predict that it might be low because of her volume depletion. She certainly is set up for this insensible water loss picture. And she broke her hip and is frail and had decreased access to water. She did not have sodium intoxication. And by way of review, we talked about these other possibilities in the previous case. So she falls here in this algorithm. And we talked a little bit about the rate of correction and the treatment of the underlying condition. Here, it's purely an inability to get to water, and we want to figure out how to correct her. And this is a little bit involved, and I'm going to walk you through it. So really, whether you're dealing with hyponatremia or hypernatremia and the treatments of, we worry about the brain. And really, what we worry about in the setting of a rapid increase in sodium is osmotic demyelination. So this could occur in the rapid onset of hypernatremia, but would not happen in the rapid treatment of hypernatremia. That would fall over here where we abruptly lower the sodium and shift the osmotic balance between the cells and the cerebrospinal fluid, leading to cerebral edema. So let me walk you through these in a little more detail. Let's start with a rapid increase in sodium. So picture with me this normal cell in the brain living at 140 equivalent milliosms of sodium. And we suddenly raise the extracellular concentration to 160. What's going to happen? Well, water is permeable across the bilayer, but sodium and other osmolytes are not so permeable. So in the short term, water is going to move out down that concentration gradient, and it's going to lead to a shrinkage of the cell. And that's what leads to this demyelination in the neuronal axons. So any rapid increase in sodium can lead to osmotic demyelination. And this, of course, is clinically most apparent and most concerning when we're treating hyponatremia and we inadvertently correct the sodium too quickly or too rapidly. In our patient, she comes in with this gradual increase in her serum sodium. And if we take that same cell and we were to rapidly lower the extracellular sodium concentration, which way is water going to move now? It's going to move towards its concentration gradient into the cell, and the cell is going to swell, not shrink as over here. And a swollen brain cell is by definition cerebral edema. And there's this very nice review, it's a few years old now, in the New England Journal by Rick Stearns that talks about this in more detail. And I find this a helpful framework to not get confused about what's happening in the brain with these changes in sodium that are rapid either in an up or down direction. So what about these other choices? So the first choice was she has intracellular volume depletion, but normal extracellular volume. But we just talked about how water distributes across all cellular compartments. So this statement just isn't physiologically correct. We don't segregate water into one space or the other. It traverses all the membranes. 3% saline could be used, but what would that do? That has a gradient of 512 milliequivalents. So we would still worsen her hypernatremia, and you would not want to choose that. What she needs is water to dilute down her sodium, not more salt, and we're not as worried about this gradient, and this would not be appropriate either. If you do that calculation that I showed you in the previous case, you would have to give her 6 liters of water. So to give her 6 liters and bring her from 168 down to 140 would be too fast, even with the caveat that I mentioned earlier that we can probably be a little more liberal in the rate of correction than we are with hypernatremia. This would still be too much. And then we talked about the difference between this. So the correct answer, as highlighted on the previous slide, with the cells swelling and shrinking, was that this would be the consequence of too rapid a correction. Right. So let's turn our attention to case 3. This is a 64-year-old woman with coronary artery disease, multiple prior MIs, and an ischemic cardiomyopathy. She has an ejection fraction of 15% and is admitted with pulmonary edema. She's on this list of medications that include metoprolol, a diuretic, spironolactone, digoxin, isosorbide, and lisinopril. She is relatively hypotensive at 97/54. JVP is 9 with moist mucous membranes. She has inspiratory crackles, an S3 gallop, cool extremities, and 1+ peripheral edema. Her sodium is 128. Potassium 3.6, chloride 87, bicarbs 34, BUN and creatinine of 46 and 1.2 with a pH of 7.48. And the question to consider after looking at her urine electrolytes, I'll show you on the next slide, but you have these electrolytes from the urine, which are obtained about 6 hours after her last diuretic dose. And you can see that her urine sodium is low at 15 milliequivalents per liter, virtually undetectable urine chloride. And as we'll learn later, that's probably the best test for determining the diuretic effect, and a UOSM of 220. So what would be the most appropriate choice for managing this patient? She's a heart failure patient. She's mildly hyponatremic at 126 or 28. So would you give her intravenous saline? Would you start her on tolvaptan? Again, that's the vasopressin receptor antagonist. Would you stop her loop diuretic? Would you restrict her to 1.5 liters, or might you add acetazolamide? So I'll give you a moment to think about those choices, and then we'll move on. So if you think about this, hopefully most selected that we would want to fluid restrict her, and that these other choices, for reasons that we'll discuss, may not be appropriate. So again, by way of review from the basic talks that we did earlier in the live session, hyponatremia should be thought of in three broad categories. And don't forget that you want to measure the plasma osmolality, because there are conditions of hyponatremia that are not hypotonic. So let's look at that. If you have a lot of glucose in the blood or mannitol, that's going to draw water out of the cells appropriately, physiologically, into the vascular space, because glucose can't be taken up by the cells, and that's going to lead to a dilutional hyponatremia. But when you measure the osmolality, it's going to be elevated. So that's not relevant here, but important to keep in mind. Then there are these conditions of pseudo-hyponatremia, where an artifact of the way the sodium is measured due to elevated lipids or protein gives you a normal serum sodium, a low serum sodium, but a normal plasma osmolality. You wouldn't need the plasma osmolality if you measured this on whole blood, but most labs, particularly from the emergency room and other places, are not routinely starting the analysis with a whole blood measurement. So hypoosmolar hyponatremia brings us down this part of the decision tree, because we've confirmed that there's hypoosmolality and there's hyponatremia. And this is where this patient falls. And as we discussed previously, this can be divided into hypervolemic, euvolemic, and edematous conditions. And it comes back to the fact that sodium concentration is predominantly regulated by antidiuretic hormone, but volume, as you remember, is regulated by the renin-angiotensin system. And the way to determine volume status, or sodium avidity, and activation of the renin-angiotensin system, is to look at the urine sodium. So volume depleted patients, as highlighted with the asterisk, will have a low urine sodium, and those patients are treated differently than euvolemic or edematous patients. But these conditions also show up with low urine sodium because, due to the pathology of the underlying organ, there's an underfilled arterial circulation. So the kidneys are seeing less perfusion and think they're being underperfused, or feels that they're underperfused. So the appropriate response to kidneys that aren't getting enough perfusion is to hold on to salt. And that's how patients with heart failure get edematous. You see it in nephrotic patients and liver failure patients as well. So you want to determine volume status. And in this particular patient, she fell into this category of congestive heart failure. And she had a very low urine sodium, and I purposely gave you that after her diuretic effect would have worn off. So consistent with this part of the decision tree. And just by way of review, ADH is our osmoregulatory hormone, and exquisitely sensitive. As the serum osmolality increases, ADH is stimulated. That works at the collecting duct to reabsorb water. And the reason we avoid hypernatremia is because we get thirsty and drink. Where everyone gets confused is the fact that ADH is also a volume regulatory hormone and will be stimulated in profound volume depletion, but also in these pathologic conditions of an underfilled arterial circulation, that you would see in heart failure, cirrhosis, and some forms of nephrotic syndrome. And you can see based on the y-axis that the amount of ADH that gets stimulated is actually significantly greater than what is measured from pure osmoregulation. So in this case, the osmolality is sacrificed at the in an effort to preserve circulating volume. And that makes sense from an evolutionary and survival point of view, that we would care less about our osmolality and more about having adequate perfusion. So that's why ADH is turned on in these underfilled conditions. So you wouldn't give this woman normal saline. She's already fluid overloaded. You could give her tolvaptan. It's an aquaretic, and that literally means it promotes water excretion, but not sodium excretion. The Everest trials showed that there was no benefit on hard outcomes for treating heart failure patients with hyponatremia with these aquaretics, so they're not typically recommended, but it will fix the sodium. We wouldn't want to do this because she requires that loop diuretic to maintain negative sodium balance and stay out of heart failure. This is a weak diuretic that works in the proximal tubule, wouldn't add much. So the correct answer was to continue or to start a fluid restriction of 1.5 liters. Okay, let's move on to case 4. This is a 45-year-old male smoker who presents with confusion and drowsiness. He's only on a bronchodilator and steroid inhalers. He does have some underlying COPD from his smoking history. On exam, his blood pressure is normal, heart rate's normal, he has moist mucous membranes, good skin turgor, normal JVP, clear lungs, no edema. Chest x-ray just shows the emphysematous changes, but is otherwise normal. But his laboratories come back with a sodium of 116 and a serum osmolality of 256. So this is true hypoosmolar hyponatremia. A urine sodium of 85, a urine potassium of 78, and a urine osmolality of 670. So what might you consider next in the management of this patient? Would you A, order a serum protein and lipid panel? B, get a CT scan of the chest? C, get psychiatry involved because you think this is psychogenic polydipsia? D, administer a thiazide? Or E, order an echocardiogram? We'll give a moment to think about those choices, and then we'll move on to discussing the correct answer and the other choices. All right. So most people probably got the correct answer in that this is likely going to be SIADH, and that this smoker likely has an underlying lung cancer as the explanation. So the question and the answer were pretty straightforward, but understanding the physiology and applying it to this case, I think is most helpful. So I showed you this previously, and we talked about it in the review lecture, dividing, again, hyponatremia into hyperosmolar, pseudo, which is why checking lipids and protein is a good idea. But in this case, we were given the serum osm, and it was in the 250s, so we knew it was hypoosmolar hyponatremia. And that brings us to this discussion point. So he falls into this arm, which was also shown in the previous case. Just take a step back, think about your patient in terms of volume status. This does not sound like a hypovolemic patient. It was not a heart failure or edematous patient. Everything in the physical exam and vital signs suggested euvolemia. And what we really want to know then is where in this branch point does this patient fall? This is a common clinical scenario that we are often confronted with, and it's really important to look at the urine osmolality, because if you're drinking a lot and there's nothing else wrong, if you have a lot of tea or beer or whatever, you're going to pee a lot and you're going to put out a dilute urine. But if you've got a pathologic condition that's stimulating ADH, the urine osmolality will be inappropriately elevated compared to that serum osmolality. And then again, there are endocrine disorders that can mimic this, so we always also think about hypothyroidism. So this patient's urine osmolality was in the 600s. So clearly inappropriate for a serum sodium of 116 and an osmolality in the 250s. So this branch point is very helpful for distinguishing these, and you will see this in terms of other questions and clinical scenarios. So the serum protein and lipid panel, as I mentioned, can be helpful if you're worried about pseudohyponatremia. Here we weren't fooled because we had the serum osmolality. B was the correct answer. Again, if he were psychogenically drinking lots and lots of fluids, then we would expect his urine to be appropriately dilute, and it wasn't. Thiazide doesn't really have a role here. It doesn't affect urinary dilution. Stimulating further sodium losses could worsen his hyponatremia. And the choice of an echocardiogram would be great if you were worried about heart failure or perhaps other valvular disease, but none of that really ties into his clinical presentation. So that was the right answer. Okay, we're going to turn our attention in the next few cases to potassium disorders. This is a 45-year-old woman with hypertension and type 2 diabetes. She presents with leg swelling and worsening blood pressure. Her medications are insulin, amlodipine, enalapril, furosemide, and aspirin. Sodium's 136, that's normal. K is 6.2, that's elevated. She has a bicarb of 20, so a mild acidosis, some moderate renal disease with a BUN and creatinine of 32 and 1.9. And she happens to have a fair bit of proteinuria, which you may not be surprised by with her history of diabetes. But we're going to be focusing on her potassium. So of these choices, which is most likely the explanation for her hyperkalemia? Does she have hyperaldo, renal artery stenosis? Does she have a type 4 RTA? Does she have a type 2 or distal RTA? Or is she just taking in too much potassium to account for her elevated serum potassium? I'll give you a moment to think about those choices, and then we'll move on to the correct answer and explanations. Okay, this could be a little tricky. I would be surprised if a reasonable percentage of the audience didn't quite connect on this. But this is a type 4 RTA, and we will talk about this in the context of potassium handling, which again is by way of review from the background lectures. So if we see a patient with hypokalemia, now remember this patient had hyperkalemia. Hypokalemia and renal potassium losses and hypertension, we're looking at things that activate the renin-angiotensin system. So by way of review, renin substrate with the enzyme renin is converted to angiotensin 1. Converting enzyme, this is where our ACE inhibitors work, prevent conversion to angiotensin 2. Angiotensin 2 stimulates aldo, whose effects on the kidneys are to promote sodium absorption, thus the hypertension, but potassium excretion. So this is important for thinking about the choices that we're given. Any condition of renal hyperperfusion will activate this system, including renal artery stenosis. What about other endocrine disorders that are associated with low potassium and hypertension? Well, we think about aldosterone, and we just went down this renin system leading to angiotensin 2. I mentioned renal artery stenosis. But here, the renin would be high, sorry, this should go here, and the aldo would be high. Whereas in primary hyperaldosteronism, the aldosterone would feed back and suppress the renin. And then there are other endocrine disorders such as, or hereditary disorders such as Little syndrome, which is a condition of activating sodium channel in the collecting duct, or other things that can mimic cortisol excess such as licorice ingestion. So again, by way of review, how do you become hyperkalemic? Well, you have to have more intake. You typically have to have decreased renal excretion. This is determined by both GFR, your underlying renal function and number of functioning nephrons, as well as hormones that we'll touch on. And then, of course, potassium is regulated in the short term by shifting intracellularly. And these are the factors that drive potassium out of cells and can contribute to hyperkalemia. Acidosis through buffering of a hydrogen inside the cell will bring up potassium out. Elevated glucose, beta blockers, digitalis, and then cell lysis is an important one in conditions like rhabdo or hemolysis, and then some rare hereditary disorders. So this person, we would worry about her intake. And then this is basically showing you kidney function, renal failure, and distal delivery of sodium. And this is showing you what happens at the collecting duct in terms of aldosterone regulation. And we use a whole host of meds that interfere with potassium excretion. And she was on several of them, including the ACE inhibitor, and I don't remember if she was on heparin, but NSAIDs and spironolactone. I can't remember if she was on spironolactone. Other meds to consider are amiloride and trimethoprim, relatively commonly used. And then a condition unique to diabetics, which is basically a hyporenin hypoaldo condition. So the type 4 RTA, which was the correct answer here, is the only RTA that gives you elevated potassium. So that usually makes it pretty easy to distinguish. And as you recall, her bicarb was 20, so she did have an element of a metabolic acidosis. You could write that off as part of her renal disease, but in this case, it was probably more related to this type 4 distal RTA. It's typically a non-anion gap metabolic acidosis with normal urine acidifying ability. It's not seen in severe renal failure, more in mild chronic renal disease, and is often associated with diabetes, but can also be seen with other disorders of the tubular interstitium, including lupus, chronic obstruction, myeloma, and NSAIDs, which can essentially mimic anything or everything. So in terms of the most likely explanations, primary hyperaldo, as I mentioned, would give you hypertension and hypokalemia. So would renal artery stenosis, as we alluded to in those previous slides. This was the correct. This was the correct answer. The type 4 RTA. The distal RTAs usually have a low potassium, and then high dietary intake often contributes. But is almost unheard of to be able to cause hyperkalemia in the absence of other factors such as renal insufficiency or meds that interfere with the renin-angiotensin and aldosterone system. Okay, a few more cases and then we'll take a break. This is a little bit shorter case that I think most people will get right off the bat. This is a 20-year-old with no past medical history, no medicines, comes in with a week of fatigue, nausea, vomiting, diarrhea, abdominal pain. He's hypotensive, tachycardic, low-grade temperature, mildly diffuse abdomen. And he's hyponatremic, he's hyperkalemic, he has a metabolic acidosis, he's actually relatively hypoglycemic, some mild renal insufficiency, probably pre-renal, and he's got a very low urine potassium. Obviously, when you see a patient like this, you wouldn't have a 24-hour urine collection, but for the purposes of instruction, this is a gentleman with a high potassium and a very low 24-hour urinary potassium, which should be up in the 40 milliequivalent or greater range. So with that in mind, which of the following tests would be most likely to reveal the underlying cause of the hyperkalemia? And by the way, it'll also explain the hyponatremia. Is this digoxin toxicity? Is this rhabdo? Do you want to get a CK level? Do you want to do an ACTH stim test? Are we looking for diabetes and getting an A1C, or doing an iothalamate GFR? I'll give you a moment to keep an eye on that and see which choice makes the most sense. Most people probably recognize that this is adrenal insufficiency and that this would be the correct answer, an ACTH stim test. Again, we showed this slide just previously in terms of hyperkalemic mechanisms, increased intake, decreased excretion, and cell shift. This patient had a very low urine potassium on the 24-hour collection. And I made that a little easier just by giving you that information up front. And I showed you this slide previously, so where does this person fall? He falls here. in the setting of adrenal insufficiency. So Addison's disease or primary hypoaldosteronism. Pretty unusual to present in an otherwise healthy person, but for the purposes of instruction, I think it's a useful clinical scenario to go through. You could also approach him from his hyponatremia, and I'll do this quickly because here it is, Addison's disease showing up under hypovolemia. He was definitely hypovolemic on his exam, so if we were to come back to our hyponatremia algorithm, he would show up here. Now in Addison's, you may not see a low sodium because of the adrenal insufficiency, but they're clearly volume depleted. But they may not be able to conserve sodium down to less than 20 in the urine. And this is just by way of other hyponatremia review. So these are easy to dismiss. This inhibits the sodium-potassium ATPase, digoxin that is, and would lead to an increased potassium. It wouldn't explain anything in this case anyway. He certainly didn't have rhabdo. We don't think that this is diabetes. Hyperglycemia would be associated with a shift out of potassium out of the cells, but this is way out of proportion and acute in onset that you would see with uncontrolled or new onset diabetes. And just by way of information, iothalamate is a marker for a formal glomerular filtration rate test. It's a compound that is not reabsorbed or secreted and is used to more formally and accurately assess true kidney function. But you wouldn't consider that in this case because it wasn't totally relevant to the way he presented. Okay, home stretch for the first set of cases. This is an 18-year-old who presents with acute muscle weakness. She's had several previous episodes that resolve spontaneously. Her blood pressure is not elevated. It's only 96/54. And the rest of her exam was unremarkable. So a young woman, muscle weakness, normal blood pressure, and a potassium of 2.9. And what else can we learn here? Sodium's essentially normal, maybe a little bit of a metabolic alkalosis, but almost within the normal range, and a normal BUN and creatinine for a petite young lady. So we get some 24-hour urine studies on her, and here I give you the ranges just because it's fair to provide that. Remember that a 24-hour urine is going to reflect what people take in. So there really is no normal for urine sodium excretion or otherwise, because if I eat a lot of salt, I'm going to put out a lot of salt, and vice versa. But normally the range is 50 to 150 milliequivalents, and her sodium was 80. Now, in the setting of hypokalemia, what should the kidneys do? And the kidneys are remarkable in their ability to adapt to the circumstances that they're dealt. So if the blood is hypokalemic, then the kidneys are going to say, well, we really want to hold on to potassium. So the appropriate response, like if you had diarrhea or other conditions, if you looked at the urine, potassium would be to be very low because the body and the kidneys are trying to conserve as much as possible. So here we see that the urine potassium is quite elevated, even above the upper limit of normal. So even more dramatically inappropriate for this serum potassium. And there also happens to be a lot of chloride in the urine as well. So these are always tricky questions, but think them through. Which diagnosis is most likely with this clinical picture? Gittleman's, primary hyperaldo, surreptitious amiloride, surreptitious laxatives, or hypokalemic periodic paralysis. And I suspect that the audience will be somewhat split amongst the choices here. And the correct answer is Gittleman's, and we'll go through why these other ones aren't correct. So I think this is the first time we're seeing this slide in this presentation, but should be a review from the review lectures. So for hypokalemia, again, we have cellular shifts. These are the opposite to what we saw with hyperkalemia. So alkalemia drives potassium into cells, insulin drives it into cells, beta agonists. These all should look familiar to folks when you're treating hyperkalemia. What do? We give insulin and glucose. We give bicarb, we give beta agonists. Interestingly, most hypokalemic GI losses are actually indirectly renal losses, and because vomiting induces metabolic alkalosis, it promotes further potassium losses, but it's really through the kidneys. Diarrhea, it's a direct loss in the stool. And then there are things, of course, that will interfere with renal potassium retention and promote K wasting. And she falls here because we pointed out that her urine potassium was quite elevated for a K of 2.9. And she was normotensive. So we would be thinking differently if she were hypertensive. We'd be thinking about primary hyperaldo or maybe renal artery stenosis, fibromuscular dysplasia in a young woman. But she's normotensive. So how do you get renal potassium wasting with normal or low blood pressure? Osmotic diuresis, variety of drugs, vomiting, renal tubular acidosis, as we alluded to in one of the previous cases, or an inherited tubulopathy. So we didn't have a history of vomiting, so we're sort of between a diuretic or one of these inherited disorders. And thinking of a diuretic and diuretic abuse is perfectly appropriate in any patient, but you could distinguish them. So in this young woman with unexplained hypokalemia, metabolic alkalosis, and normal blood pressure, the differential includes these items. Hyperaldo, of course, is associated with volume expansion and hypertension and a high urine chloride. These other three are associated with normotension or mild hypotension and can be distinguished based on the urine chloride. Because vomiting is a condition of metabolic alkalosis, there's filtered bicarbonate, which promotes sodium and potassium losses, and chloride will become vanishingly low in the urine as a marker of the volume depletion. Diuretics, of course, promote sodium and chloride excretion, so they would have an elevated chloride, as would the inherited disorders that mimic diuretics. So to distinguish these, you would need a diuretic screen. So she fell into this category, and you would want to distinguish diuretic abuse from the inherited tubulopathy. So you might do the diuretic screen. But in here, there was some other family history and other things that may have suggested it. So the correct answer was Gittleman's, a recessive mutation in thiazide-sensitive transporter. We talked about primary hyperaldo numerous times, hypokalemia and hypertension. Amiloride use is a case-sparing diuretic, so you wouldn't see a low serum potassium. Laxative abuse is a choice that several folks or a significant percent of the audience may have picked. But again, nothing wrong with the kidneys. You're losing potassium in the stool. What should they do? They should hold on to potassium, and the urine potassium should be very low, and that wasn't the case here. Similarly, in this rare condition of hypokalemic periodic paralysis, it's a problem with shifting potassium, so you wouldn't see an elevated urine potassium. So that was the correct answer. Okay, move on to the next case. A 74-year-old woman with hypertension at the age of 40 has worsening blood pressure over the past few years. She's now on amlodipine, lisinopril, hydrochlorothiazide, atenolol, and clonidine. And her blood pressure is 156/78. Her sodium is normal. She's hypokalemic. She has a little bit of an alkalosis, moderate renal insufficiency with a creatinine of 2. And she has a renin of 8.5 and an aldo of 24, with a normal range of 1 to 6 and 5 to 20, respectively. So high renin, high aldo, hypokalemia. What might you think of? And which test would give you that answer? Would you get a CT scan of the adrenal glands? Would you do a dexamethasone suppression test? Would you check a urine diuretic screen? Or would you do a Doppler ultrasound of the renal arteries? I suspect the majority of the audience will get the correct answer here, as this is most likely what? Underlying renal artery stenosis, and this would be the best test to get that. I've showed you this before, high renin, high aldo. Virtually nothing else will give you that picture. It fits with the high blood pressure. It fits with the low potassium. The only other condition that I've never seen is a rare tumor in the kidneys of a reninoma. So if you have large amounts of renin being secreted by a tumor, it'll mimic renal artery stenosis. I've never seen one, but obviously they exist. We should think about it. So she falls here. By way of review, the renin, angiotensin, aldose system, whereas in hyperaldo, the high aldo feeds back and suppresses renin, and both her renin and aldo were high. So this is the test you would look for primary hyperaldo, but her biochemistry doesn't fit with that. Dexamethasone suppression you might use to rule out Cushing's disease, but the aldo is usually normal or low. We're not really worried about diuretic abuse in this situation. And of course, the Doppler ultrasound of the renal arteries would be the best test. And there are others that one could consider. Okay, so last case for this session. It gets a little more complicated. This is a 28-year-old who is found unconscious in the street, brought to the emergency room. No medical history is available. His blood pressure is 120/75. He's breathing at 12 a minute. He appears disheveled and is comatose and responsive only to pain. His pupils are reactive to light. He has a non-focal neuroexam. Doesn't have an odor, no fetor. He's intubated, goes lavage, charcoal. Some of these approaches in ED may be a little dated, but the presentation is not. And he presents with these electrolytes, so nothing really to speak of initially till you get to his bicarb, where he has a profound acidosis, some moderate renal insufficiency, normal glucose. You get back other results showing no alcohol, negative acid test, negative beta-hydroxybutyrate, really negative lactate, no salicylate, normal CPK, serum osm of 308, and you get back his blood gas, which shows acidemia, 722, and a PCO2 of 24. So what's the next best step in the treatment of this patient? Would you give him dopamine? Would you dialyze him? Would you force an alkaline diuresis? Would you give him thiamine or famotidine? I'll give you folks a moment to think about the correct answer. I suspect most will get this right. And the correct answer with subsequent explanation will be coming. And the correct answer is famotidine, because this is an example of an alcohol intoxication. And famotidine blocks alcohol dehydrogenase and can prevent the accumulation of toxic metabolites. So the toxic metabolites, if you've consumed ethylene glycol, would be glycolic acid, and if you consumed methanol, it's formic acid. Neither of which sound very good for your body. They're not. This is a nice New England Journal review. It's now over 10 years old. Ethylene glycol ingested, absorbed by the liver, alcohol dehydrogenase converts it to glycolic acid, and you can block that up here with famotidine. Glycolic acid gets converted to oxalic acid, causing calcium oxalate crystals, can cause renal failure. You can see the calcium oxalate crystals in the urine. You can even see it in the eye grounds on occasion. Had it been methanol absorbed in the blood, it gets converted to formic acid. Gets converted to formic acid here in the liver. Again, you can block that conversion to the toxic metabolite by using famotidine and preventing the formic acid. The major end organ of damage is the eye and blindness with methanol toxicity. So, last case, first one of acid-base. We'll have a bit more of this in part 2. But you will recall from our approach to acid-base disorders that you want to approach them in a systematic way. And we have a patient with 7.22 pH, so he's acidemic, PCO2 of 24, and a bicarb of 10. So the first thing we want to decide is acidemia, alkalemia. That's pretty easy. He's acidemic, and the primary process is his metabolic acidosis, because a PCO2 of 24 would do what? Would give you an alkalosis. So he has acidemia with a primary metabolic acidosis. And the next thing you want to do is look for compensation. And I showed you the Winters formula previously. If you plug that in, you're going to get a predicted PCO2 of 23, which is within the plus or minus 2. So there is no other respiratory disorder here. This is the appropriate compensation for that degree of acidosis. And then you then want to look at that acidosis and decide whether it's an anion gap or a non-anion gap. And you find that it's quite elevated at 24. So he has a metabolic acidosis that's an anion gap acidosis. And you would then look at the delta-delta, or the change in anion gap over the change in bicarbonate, which in this case is essentially identical, or the ratio is 1. So it essentially excludes another underlying primary acid-base disorder. So this is a pure anion gap metabolic acidosis, and you would treat it initially with famotidine and then most likely with dialysis. Another clue to this case that everyone needs to remember for the boards and for emergency room and occasionally even in primary care is to calculate the osmolar gap. The calculated serum osmolality is from 2 times the sodium plus the glucose over 18 and the BUN over 2.8. These just convert milligrams per deciliter to millimoles. And a normal osmolality is about 280. And this person's was actually 28, because if you plug in so this would be essentially his a normal osmolality, and this was his gap. He was measured at 308. So those were his numbers for sodium, glucose, and BUN. Calculates to 280, measured at 308. So the gap was 28, elevated. And I'm going to go through this quickly because we did it in the first lectures, but here's the breakdown of how you think about anion gap acidosis and osmolar gap. Salicylates, normal osm, elevated anion. These ingestions, anion gap and high osmolar gap. And then the opposite is no gap acidosis, but an osmolar gap with isopropanol. And this would be ethylene glycol. This is by way of review from the original discussion earlier. You can see this with methanol. I'm going to go through this quickly for the sake of time. There's the calcium oxalate crystals. You've all seen this before. So the next step in this guy's treatment would be to give famotidine. He probably will need dialysis. No role for these other interventions. Although a forced alkaline diuresis is something you would consider for salicylate ingestion, but not for alcohol toxicity. So that's the end of part 1.